Hi, Dr. Reed. This is Jay Nunez. This is my project. This is probably the 15th time I've recorded this. I tried my best with the share pat, with the screen power or whatever. Wasn't recording, so here I go. I'm doing it through Zoom. I'm sorry. I'll take the point deduction. I'll email it to you. I'm starting the clock just so you know, just in case. I'll show you after. Okay, so my project is amyotrophic lateral sclerosis, also known as ALS. What is ALS? ALS is also known as Lou Gehrig's disease. It is a progressive neurodegenerative disease that affects motor neurons in the brain and spinal cord. It affects the lateral side of the spinal cord, which contains the nerve cells that control the muscles. The cells degenerate and go through sclerosis or hardening. According to ALS.org, when the motor neurons die, the ability of the brain to initiate and control muscle movement is lost. When voluntarily, when voluntary, when voluntary muscle action is progressively affected, people may lose the ability to speak, eat, move, and breathe. It progresses until death, usually by respiratory failure within 2 to 5 years of diagnosis. There's no known cure for ALS. On the left side here, I have a picture of the normal nerve cell that shows the muscle contraction. And on the right side, it has the nerve with the sclerosis or ALS, and the muscle is unable to contract. Pathophysiology. The protein aggregates form in the cytoplasm of the neurons in the motor cells. Proteins misfold and stick together, aggregate, called inclusion bodies. It aggregates with these proteins, the TDP, the SOD, and the FUS. These inclusion bodies cause neuron death and sclerosis. Multiple pathways for possible neuron death. There's multiple pathways for possible neuron death. So one pathway is the glutamate. The glutamate mediated exotoxicity. It transport protein for glutamate disposal is mutated. So the glutamate can't be uptaken into the astrocyte and disposed. The glutamate accumulates in the synapse of the motor neuron, and then the glutamate in the neuron causes the calcium channels to open up, and it causes excess levels of calcium in that neuron. And this creates an exotoxicity in the cell death. So on the right-hand side, I have the summary of the pathophysiology of it and the glutamate. Genetics of ALS. ALS is idiopathic, means that it just comes out of nowhere. It arises spontaneously in 90% of the cases with no family history of disease or genetic association. According to ALS.org, for 5 to 10% of all cases, there's a known family history of the disease, and is often called familial ALS. For familial ALS, there's a 50% chance of children to receive the mutated genes. It is autosomal dominant, meaning that it only needs one copy of the gene to develop in the disease. It's very prevalent in military veterans. They're more likely than the general public to develop ALS, and for those reasons, they are unknown. At least 16,000 people in the US may currently have ALS. Symptoms of ALS. So muscle twitching, it consists of muscle twitching, cramping in the hands and feet, tight and stiff muscles, muscle weakness, slurred speech, difficult swallowing and chewing, falling or tripping. It has behavioral changes such as inappropriate crying and laughing. And then towards the end, it progresses to respiratory distress and failure and the inability to move, and which is also paralysis. So I'm not going to go through all my ALS progression timeline, but in the early stages, it causes muscle weakness, twitching, cramping, fatigue, poor balance. In the middle stages of ALS, it's more severe. For the muscle weakness, you have some paralysis in the muscles. You have difficult chewing, talking, swallowing, and in the later stages, it's mostly all paralysis. So you're basically can't move. So paralysis is in most of your muscles. You have extreme mobility. You have limited mobility. I mean, you're also unable. You have the inability to speak, breathe, talk, eat, and drink on your own without assistance. The effects of ALS on exercise. ALS is progressive. The muscles continue to get weaker and eventually lead to paralysis, which can ultimately affect exercise in the end. Therapy can help slow down the progression of muscle atrophy, and also increase the quality of life. Management and medication. So there's no cure for ALS. I did some research and found that there's 7 drugs approved by the FDA to treat ALS. It's mostly for pain relief, or they have some to reduce the damage between the motor neurons. One example I found is the rulazole. It's an oral medication believed to reduce the damage of motor neurons by decreasing levels of glutamate, which I talked in the previous slide, which transports messages between the nerve cells and the motor neurons. Clinical trials in people with ALS show that the rulazole prolongs their survival by a few months. There's also 2 more medications. One is a thickened liquid form, and the other one's a tablet, and they both dissolve on the tongue, which helps anyone who has trouble swallowing. Overall, it slows down the progression of ALS on the body. There's other medications that can treat the symptoms, but not treat the cause, like the cramps, the stiffness, the emotional distress, the pain, and the constipation. Management and medication. So baclofen and diazepam can be used to treat muscle spasms. Medications can affect the patient's ability to physically rehab or exercise. The example is rulazole. The side effects can cause nausea, tiredness, weakness, joint pain, headaches, etc. And then these side effects can ultimately also interfere with the patient's ability to participate in their therapy. People you may know with ALS, one famous person is Stephen Hawking. We all know him as the world-renowned scientist. He lived with ALS for 55 years, which is unprecedented, because the life expectancy is usually 2 to 5 years. He was known to be wheelchair bound, and he has a voice synthesizer. He was diagnosed in 1963 at the age of 21 and survived all the way to 2018, where he died at the age of 76. People contribute to his long life because he had unlimited medical resources, as having 24-hour care, and he had a team of nurses on call at any time. So that helped him live longer. He's also the longest surviving ALS case currently. Another famous person is Lou Gehrig, whose disease was named after him. He had symptoms during his season in 1938. They found out when he was weaker and his batting average fell below 300. He was having trouble tying his shoes, and then he died after his poor season, and died in 1941. So my case study is a 45-year-old Caucasian man named Gene, and he was diagnosed with sporadic ALS, which is the most common ALS in the US and makes 90 to 95% of the cases. Prior to the diagnosis, Gene was moderately active and had regular exercise routine, and his current routine consisted of running, walking, and hiking. Gene has no past medical history of the disease, nor in his family. For several months prior to his diagnosis, Gene had lower extremity weakness. He had mentioned that he has lost some muscle mass, as well as has some muscle spasms throughout his body. Recently, he has been trouble communicating and having slurred speech, but his parents are living and are in good health. Conversation with my patient. So I had a conversation with Gene. We discussed we would like to have the best quality of life with him while he's with the disease, living with the disease. This meaning he would like to stay active as much as he can, preserve as much muscle mass as he can before he becomes weaker. His doctor informed him he has 2 to 5 years to live. We can provide medication in the future in order to reduce his pain or deal with the ALS. He said he would also like his therapist to help create exercises such as myself and medication care to help him when he needs it in the future, when he's having trouble eating, speaking, and walking. So my exercise prescriptions include walking, swimming 20, 30 minutes a day, moderately intensity. This will be around 2 to 3 times a week. His weight resistance, I want him at a comfortable weight, 15 or less repetitions, no max weight or reps. I'll talk about this later, but I want him, if he could do 20 I want him to do half of that, do 10. We don't want him to overexert his muscles, because it's just going to make it worse. Gene has a normal, pretty regular blood pressure. So this is his prescription. He's 6'1", 186, BMI 24.5. He's 45 years old, non-smoker. His levels are pretty normal. His fasting blood sugars 84. Individuals with ALS have decreased levels of fitness to peers without this, compared to peers without disabilities, even though there's no evidence of how increasing muscle strength is in a person with ALS will benefit in the long run. Is our main goal as healthcare providers and therapists to preserve that muscle strength and that muscle deconditioning due to the disease. Our overall goal is to keep the patients active and maintain and preserving his muscles. ALS is terminal and progressive, so it is note that a muscle atrophy is inevitable. This means that it is impossible to maintain muscle mass with Gene's illness, and we can try to slow down the progression to keep the best quality of life for him during this regimen. Exercises would help Gene preserve this. Exercise that would help would be the stretching and flexibility to prevent muscle tightness and stiffness and reduce the pain. We can also include the disease. We can also include aerobic activities such as walking and swimming. I know aquatic exercise is perfect, as it would benefit Gene, allowing him to move in an unweighted environment with like gentle resistance. We would avoid using a treadmill, hiking, uneven surfaces in case he won't increase the risk of falling. For strength exercises, our main goal is to preserve that muscle strength as best as we can. We would like adjust his weightlifting to avoid high resistance and max strength exercises. We would lower it to moderate intensity. We would choose a comfortable weight. So if he could do 20 reps, we would like him to do half of that. That way we don't overuse his muscles. A good practice for patients with ALS would be to add as much muscle mass onto the patient at the beginning of their illness as possible. That way, the more muscle, thus it will take longer for the atrophy to happen. His regimen is frequency, I would say, every other day, 2 to 3 times a week, and intensity would be moderate. We would like to preserve the muscle and build the strength, not overwork his muscles. It would be 20 or 30 minutes at a time. We would add aerobic and muscle strengthening. We would include walking, swimming, yoga, stretching. The volume would be a reasonable weight, comfortable for him. I talked about this previously. If he could do 20 reps, we will keep him at 10 or 15. That way we don't overexert him. Depending on how he's feeling, we would reduce the weight or increase the weight, I would say slightly, about maybe 5 to 7% max. We don't want him to do that 10%. And it depends how he's feeling up to it. In conclusion, overall, there's no cure for ALS, just maintaining the quality of life as much as possible. There's medication that can help possibly prolong his illness, but there's no cure. It would also help reduce his pain, and therapy and his healthcare is vital to keeping him active. So we're just trying to keep him active, keep him moving, just trying to preserve all his muscle and just his quality of life overall. My next slide is my references, and that should be it. My time is around 13 minutes just to show you. I'll stop it now. Thank you very much.